Thank you, Dr. Maxwell. Now we'll be pleased to hear from Dr. Tandra, also specializing in breast cancer. He's a medical oncologist at UNMC.
Thanks, Nate. This is Pavan Tandra. I'm one of the medical oncologists at UNMC. And I'm asked to talk about breast cancer management and what I do. And also, I changed the title a little bit. I was asked to talk about, is breast cancer one disease? Simplest answer is no. Why is that? And I'm going to go through a few slides. I don't have any disclosures. What do we do? So what do medical oncologists do is basically, we are a part of the multidisciplinary team in breast cancer. We work with radiation oncologists and surgeons, and we discuss all the patients with surgeons and radiation oncologists before we go to see the patient. And so in the multidisciplinary clinic, when a patient comes, we gather all the information about stage of the disease and what risk factor of breast cancer and how we can prevent it from recurring in future. And how are you going to go with a cure or palliation? And if we are going with cure, how are we going to cure it? If we are going with palliation, how are we going to palliate it? And what's the best strategies available? So as Jessica said, one of the options is sometimes we de-escalate the tumor, especially the large tumors more than 5 centimeters. And how do we do it? By giving chemotherapy. And sometimes patients go for upfront surgeries, and we do give adjuvant chemotherapy, post-operative chemotherapy afterwards. And why do we need to give chemotherapy? I'll go and discuss that in the next few slides. So is it one disease? No, it is heterogeneous. In the breast, if you see 2 spots, 2 lesions, and both spots can be 2 different types of tumors. That's very important to understand because we have to talk to the pathologist and biopsy both of the lesions and make sure that they both belong to the same category of disease. One can be a triple negative disease, one can be a HER2 positive disease. Even in the breast and lymph nodes, we biopsy both, and both will be clipped because to understand, to make sure the surgeon knows where the disease was. Again, we need to stain the tumor in both breast and the lymph node because breast cancer is not one disease. We need to understand what type of disease, wherever it was. And sometimes we see metastatic disease, breast, lymph node, and liver, for example. We need to biopsy liver, definitely, because we always try to confirm the metastatic disease first, and then try to understand the type of disease in the liver and sometimes in the breast. So this is the differences in the biology and difference in the levels of aggressiveness. Biology gives us information about aggressiveness of the tumor. It can be indolent, it can be very aggressive. Aggressive tumors usually respond to chemotherapy, cytotoxic chemotherapy, and differences in levels of sensitivity to cytotoxic chemotherapy. So basically, what we call is kind of chemotherapy sensitivity testing, and it can be done when the tumor is there, which means neoadjuvant chemotherapy can be given to test the chemotherapy sensitivity of the particular tumor. So that will be helpful sometimes. So what's biology? So breast cancer is divided into multiple subtypes based on the receptors, the protein expression on the tumor cells. So what we know so far is 3 types of protein exist, and maybe there are more, we don't know yet. So the types of protein we are looking for, because we know about them, is estrogen, progesterone, and HER2. Out of these 3, 2 are very, very important, estrogen and HER2, because most of the estrogen positive tumors are also going to be progesterone positive. It can be checked by pathology immunohistochemistry staining, and that gives us some information about how strong or how weak the staining is and how many cancer cells are positive for that staining. Could be 90%, could be 80%. The more the staining, the more strong the staining and the more number of cells, and that tells us that the tumors are sensitive to estrogen blocking treatment, tamoxifen, aromatase inhibitors, and things like that. So the weaker the staining, they are still going to be sensitive to the estrogen blocking treatment, but they are going to be lesser benefit compared to someone having a higher estrogen receptor expression. And the other protein we look at is HER2. HER2 can be checked by immunohistochemistry staining. It could be no staining, little staining, 1+, kind of borderline staining, 2+, and 3+ is strong staining. 3+ is definitely positive. 2+, sometimes we do another test called FISH test to see whether it's really positive or not. So based on the estrogen and progesterone and HER2, we can divide the tumors into estrogen positive tumors, estrogen negative tumors, estrogen positive, HER2 positive, estrogen positive, HER2 negative. So you can see breast cancer is not one disease. It's like multiple different types, which demands different types of treatment. Some of these tumors, what I just mentioned, may be sensitive to chemotherapy. Some of them, they may not be sensitive to chemotherapy, but they may still offer benefit in terms of survival. So we look at sensitivity to chemotherapy. We look at the survival advantage offered by some of these chemo-sensitive drugs or targeted drugs or biologic drugs, whatever we call. So this is, this information is very useful to understand the biology of the tumor. And multiple subtypes at molecular level too. And we really don't use this as a clinician, I really don't use this information right now. It's not really prime time, but this information is very helpful in terms of research, whether the tumor is luminal A, luminal B, basal, or HER2 negative, HER2 type. So we get this information at the molecular level, and breast cancer can be divided into different types at the molecular level too. I just want to give you an understanding about how we look at these tumors. And the traditional old pathological information, we still use it, looking at the grade. Grade is determined by the tumor, the tubular formation in the breast, and nuclear, how the nuclei look like, and the mitotic index, how the cancer cells are dividing under the microscope by using a stain called Ki67. So all this information is put into one grade. It could be grade 1, 2, 3, 3 basically being aggressive, and aggressive tumors respond to cytotoxic chemotherapy, as I said. And mitotic index we look at, and Ki67 I just talked about, offer information when gene expression profiles are not available. Gene expression profiles basically give us the information about the tumor subtypes at the molecular level, luminal A, luminal B, basal, and HER2. So when we don't have that information available, we can just use grade and the mitotic index and Ki67 levels as the surrogate markers for the molecular subtypes of breast cancer. So what's staging? We also look at staging, like staging. So biology, we just talked about the different types of tumors, different biologies informs us the nature of the breast cancer, how is it going to respond, what I'm going to give it to this patient to achieve the cure, the ultimate goal. And staging informs the anatomic extent of the tumor. Like staging gives me the information about whether this tumor can be curable. If it's stage 1, stage 2, stage 3, practically they are curable tumors. Cure is defined as something like we give aggressive treatment with surgery, chemotherapy, and radiation, do whatever we could do, and complete the treatment in 6 to 8 months. And then we tell the patients that, yes, you're cured, and there is a chance of recurrence, but you're cured. Metastatic disease stage 4, we cannot cure them, but we can treat them for a very prolonged period of time. So staging gives us the anatomic extent of the tumor. In other words, it gives me the prognostic information of the patient. And staging also informs us about the chances of curability, as I just said. So we look at both the biology and staging. They both are taken into consideration to determine the risk of relapse. The relapse can be local relapse, which is basically relapse in the breast, in the ipsilateral breast, in the same breast where the cancer happened, and systemic relapse somewhere else, bone, liver, lymph nodes, brain. There's a favorite size for breast cancer recurrence or metastasis. So we look at systemic recurrence and local recurrence. So when the surgeon cures the breast cancer patient, the radiation oncologist thinks about what are the chances of local recurrence. The way he defines, I'm sure Dr. Wall is going to talk about it, is basically looking at the staging, anatomic extent of the tumor. How big is the tumor? How many lymph nodes are involved? That will determine the local risk of the tumor, based on which he will determine what type of radiation needs to be given. So what I do as a medical oncologist is, what are the systemic recurrences of this cancer going to be? What are the recurrences? Basically 10% or less, or more than 10%. How do I decide that? I use a lot of tools. Some of them are available on the computer using grade and stage and estrogen receptor status. If I can just plug in those values, that gives me the value. That gives me the systemic recurrence percentage. And based on which I determine the aggressiveness of my treatment. Is going to be cytotoxic chemotherapy with 2 drugs or 3 drugs, or do I need to add a targeted drug? So biology and staging are taken into consideration. All right, systemic therapy. I just talked about systemic recurrence. Systemic recurrence is recurrence somewhere else. Basically, recurrence at somewhere else, which is basically going to be incurable disease. That's what we are trying to prevent. To cure breast cancer, we need to prevent the incurable disease, which is at a metastatic site. The chances of that can be more than 10%, up to 50% in a stage 3 disease, or it could be less than 10% in a stage 1 disease. So how do we, like if the chances of recurrence is more than 10%, we usually give chemotherapy. That happens in HER2 positive disease if the tumor is more than 5 millimeters. Happens in triple negative disease, which is estrogen negative or progesterone receptor negative and HER2 negative, triple negative disease. If if the tumor is more than 5 millimeter. Sometimes it may not happen up to 5 centimeter, lymph node disease and estrogen receptor positive HER2 negative disease. So different types of tumor, different types of systemic recurrence. So we may be able to avoid chemotherapy up to 5 centimeter in an estrogen receptor positive tumor, but we can't avoid chemotherapy in a 5 millimeter HER2 positive disease. So that's how the staging information and the biology of the disease helps us in determining the systemic recurrence and the type of treatment. So targeted treatment, anti-estrogenic therapy, like those who target the estrogen receptor, and HER2 therapy, those who target the which target the HER2 receptor. How do we use this information? Size and lymph node status. We determine who needs further staging workup. For example, if someone has 1 or 2 lymph nodes clinically positive, looked on the is there on the ultrasound or mammogram, we usually go and look further. Is the disease somewhere else, liver, bone? So we do a PET scan or a CT scan, chest, abdomen, pelvis, and bone scan. So staging helps us to look for the disease. And who needs surgery first or chemotherapy first approach? Dr. Maxwell just talked about neoadjuvant chemotherapy, which can de-escalate, which can help us to shrink the size of the tumor. So a mastectomy can be converted into a lumpectomy. So if someone needs surgery first or chemotherapy first, we take into so many things into consideration, right? Can the tumor is chemosensitive? Can we shrink the tumor size with chemotherapy? If not, maybe upfront surgery may be a best option. If we have a disease such as triple negative and HER2 positive disease, which can be shrunk with very good chemotherapy drugs available right now, there is a 50 to 60% chance that we could shrink the tumor of 5 centimeters to maybe 2 or 3 centimeters. That will allow the surgeon to remove a lesser tissue than a bigger tissue. So by converting the mastectomy to lumpectomy. So those decisions are made in the multidisciplinary clinics. So if we decide chemotherapy approach chosen, what type of chemotherapy? That will be decided by me, what type of chemotherapy you need to give and what are my objectives, like what is the curability of this disease, how much is the response to the given chemotherapy. So based on, and whether the patient can take the chemotherapy, performance status of the patients. We treat patients, not cancer. So we have to look at the patient first and see if I do all these things, am I able to achieve my objectives? So we look at all these things and balance these things and decide whether 2 or 3 drug regimen is appropriate. I think that's it. Thank you very much.
Thank you, Dr. Tandra. We appreciate your